Welcome to Diabetes Day by Day, the American Diabetes Association's official podcast. I'm Dr. Neil Skolnik, professor of family and community medicine in the Sidney Kimmel Medical College of Thomas Jefferson University. And joining me is my co-host.
I'm Dr. Sarah Wettergreen, an assistant professor in the Department of Clinical Pharmacy at the University of Colorado Skaggs School of Pharmacy and Pharmaceutical Sciences. In this role, I practice as an ambulatory care clinical pharmacist at the UC Health Lone Tree Primary Care Clinic.
Also joining us today are two experts in the field, two cardiologists who have been truly instrumental in organizing the clinical trials and carrying out clinical trials that have taught us so much about the medications that we use. First, I'd like to welcome Darren McGuire, who is the Distinguished Teaching Professor, Jerry H. Mitchell, MD Distinguished Chair in Cardiovascular Science, and a professor in the Department of Internal Medicine at the University of Texas Southwestern Medical Center. Welcome, Darren.
Thanks, Neil. It's great to be here.
And I'd like to welcome Mikhail Kosiborod, who is Vice President of Research at St. Luke's Health System, Director of Cardiometabolic Research, and co-director of the St. Luke's Michael and Marley's Haverty Cardiometabolic Center of Excellence at St. Luke's Mid-America Heart Institute, as well as a professor of medicine at the University of Missouri, Kansas City. Welcome, Mikhail.
Always a pleasure to be with you, Neil.
Sarah, if you don't mind starting us off, can you tell us about Heart Month and why that's important for people with diabetes?
Absolutely. So February is American Heart Month. So all month we are going to be thinking about heart health a little bit more. So today we're diving deeper into this topic of heart health and how people with diabetes can reduce their risk of having events like a heart attack or a stroke. Heart disease is the #1 cause of death in the United States. For people living with diabetes, the risk of having heart disease or a stroke is twice as high as for someone who doesn't have diabetes. So when we think about emphasizing this topic and thinking about emphasizing the focus on heart health, it's especially important for people living with diabetes.
Thanks, Sarah. In the old days, the key to cardiovascular risk prevention was getting our blood sugars to goal, as well as good control of high blood pressure and cholesterol. Darren, can I ask you to tell our listeners about the evolution, and we might even call it a revolution, that's occurred over the last decade with regard to choices around glucose-lowering medicines and their effect on cardiovascular outcomes?
Yeah, sure. Thanks, Neil. And it really has been a revolution. Just a little bit of history. I got interested in diabetes from a cardiology perspective over 25 years ago now. And that interest arose from the fact that, one, we really didn't understand how severe the cardiovascular consequences were associated with diabetes at the time. We were very focused on eye disease and kidney disease, and that's all very appropriate, but we really weren't paying attention 25 years ago to the cardiovascular complications, the heart disease and stroke and heart failure. And we really didn't have therapies available, even proven safe, much less effective for cardiovascular risk. And so I jumped into this field and have stuck with it for 25 years. Mikhail joined soon along the way. And so we've been working together for over 20 years now as in a community and bridging our disciplines between cardiology and endocrinology and primary care and really coming together for the benefit of the patients. And so we set out to start studying these medications specifically for cardiovascular disease. This was really amplified when the FDA and the European regulators began requiring cardiovascular safety assessments of all new drugs for diabetes. That began in 2008. And so we quickly began around the world designing and conducting randomized clinical trials specifically focused on heart disease. Primarily initially just to prove safety of these medications. While we're treating the eye and kidney disease risk, we need to be certain that we're not harming cardiovascular risk. And ultimately, as you've mentioned, we've now discovered a couple of classes of medications that have truly revolutionized the care of patients living with diabetes, and that is the GLP-1 receptor agonist and the SGLT2 inhibitors that in multiple clinical trials in each of these classes have proven not just safety, but incremental cardiovascular benefit, reducing the risk for heart attacks and stroke and cardiovascular death and for heart failure. And so it's really a whole new era. And fortunately, these new medications have much fewer side effects than the old drugs like the sulfonylureas that cause low blood sugars and weight gain and other side effects. These drugs are really well tolerated and have the added benefit, independent of their blood glucose effects, added benefit of cardiovascular risk reduction. So it's a brand new era, and our patients are benefiting.
Within these classes, I often think of these being sort of a win-win. We're not only thinking about diabetes and improving glucose management, but these other benefits that we see in both of these classes of medications as well. Darren, can you tell us a little bit more about some of the additional effects that we see with both GLP-1 receptor agonists and the SGLT2 inhibitors in regards to cardiovascular risk reduction, glucose management, and beyond?
Right. Each of these classes of medications have a number of secondary effects unrelated to their effects on glucose that probably contribute to their cardiovascular risk reduction. The GLP-1 receptor agonists lower blood pressure a little bit, 2 or 3 or even 4 millimeters of mercury. So it's not a large blood pressure effect, but it is additive and beneficial over long periods of time. The GLP-1 receptor agonists help patients lose weight. Patients who are overweight or obese, they're very effective at losing weight. In fact, at the highest doses, they're the most effective drugs we've ever had available to help with weight loss. And again, over time, that's going to favorably affect cardiovascular risk. The lipid modifications are beneficial on average. And so other things other than glucose. And to be quite honest, though, at the end of the day, we don't know exactly how the GLP-1 receptor agonists are improving atherosclerosis or blocking hardening of the arteries. So that's the GLP-1 receptor agonists. The SGLT2 inhibitors have a large spectrum of cardiovascular benefits well beyond their blood glucose effects. They lower blood pressure, they reduce the risk for heart failure, they slow down the progression or even halt in some patients the progression of kidney disease that's commonly associated with diabetes. And so all of these secondary effects, and again, most all of them are completely independent of blood glucose control, but at the end of the day, these are very good drugs for controlling blood glucose.
Yeah. So with that, and thinking about people living with diabetes and they might be interested in using these medicines to lower their risk of heart disease, are they for everyone with diabetes to lower their risk, or are there certain populations we're thinking about where we might prefer these for that heart benefit?
Sure. So there are subpopulations of patients that derive probably the greatest benefit from these drugs. I will say these drugs are approved for the treatment of hyperglycemia independent of cardiovascular disease or risk. And so they could be used for anyone living with diabetes, with type 2 diabetes. But where we've demonstrated and others have demonstrated the cardiovascular benefit has typically been in patients with advanced cardiovascular risk, either multiple risk factors like high blood pressure or high cholesterol or smoking or obesity, or some degree of kidney disease, or even having had a cardiovascular event already. Patients with or at highest risk for heart failure particularly benefit from the SGLT2 inhibitors. People with any diminished kidney function tend to benefit, even independent of diabetes, but persons with diabetes with any compromised kidney function can benefit from the SGLT2 inhibitors as well.
You know, it's interesting, and Mikhail, I'd like to ask you, because you run this cardiometabolic center for excellence, and people come in with diabetes and a range of risk factors for heart disease and stroke. And in your center of excellence, you're obviously, right on top of these things, something that in the primary care world, where many of our patients go, a question comes up. One, should they feel comfortable asking their doctor or nurse practitioner or PA if they have cardiovascular risk factors, and if they have cardiovascular disease, would one of these two classes of medicines be helpful? Two questions for you. Should they feel comfortable prompting their physician, is this useful to me? And the second question is, can they be used together?
They're both excellent questions, Neil. Thank you. So first of all, we see, this is what we do in the Cardiometabolic Center of Excellence. We see people that typically have diabetes, majority with obesity, and either established cardiovascular disease, atherosclerotic cardiovascular disease, that's blockages in the blood vessels, or heart failure, a combination of both, and many with kidney disease as well. But we certainly see people that have multiple risk factors, but yet have not yet been diagnosed with cardiovascular complications or kidney complications. And the answer to the first question is absolutely yes. Patients should be empowered to have conversations with their clinicians, with their physicians, nurse practitioners, physician assistants, to really figure out whether one or both of these medications may be the right medicines for them. As Darren said, this has really been a revolution in how we think of managing diabetes, and even thinking about what type 2 diabetes is as a disease, right? We used to think, putting an equal sign between type 2 diabetes and elevated blood glucose, and that's what we've kind of focused and fixated on, is lowering blood glucose. But we understand now that type 2 diabetes is a very complex systemic disease of which elevated blood glucose or hyperglycemia is just one facet. And there are lots and lots of other things that go on that ultimately increase the risk of complications. And you've got to have this comprehensive approach. And these medicines, GLP-1 receptor agonists, SGLT2 inhibitors, and some others that are emerging today, obviously, the field of medicine in this regard hasn't stopped. We continue to look for other efficacious therapies. They can really dramatically not just reduce the risk of complications, but some of these medicines, especially if you have heart or kidney disease, can actually significantly improve how you feel, to make patients feel better and be able to do more. I mean, these are what we call a triple goal of care in people with chronic disease: live longer, stay out of the hospital, feel better, and be able to do more. And in the right patient population, these medicines actually have the ability to do that. So patients absolutely need to have that discussion with their clinicians. They should be empowered to do so. And there is a very large segment of individuals living with type 2 diabetes that can benefit, either in terms of preventing the complications from developing to begin with, or if they already have complications, preventing those complications from getting worse. To your second question, the answer is yes as well. They can be used together. We have relatively limited amount of data on what happens when they use together, but the data we do have that's available suggests that they can be quite complementary in their protective cardiovascular effects. In particular, one recent trial, for example, of a GLP-1 receptor agonist suggesting that their benefits are independent of whether patients also receive SGLT2 inhibitors or not. And in fact, data is, while limited, is compelling enough where in the standards of care for diabetes that are issued by American Diabetes Association, it now clearly states that you should consider potential in the right patient population using these medicines together. So I'm a really big advocate for patient empowerment. I think if you have a chronic disease like type 2 diabetes, you really need to work with your clinicians or clinician team. But you really, you're really in a great position if you can educate yourself about the treatment options available and have informed discussions with your clinician about what the best next steps are in your management.
That's so important. I'm so glad that you said that, because that really, Sarah, is the core reason why ADA is having this podcast, so that people with diabetes can educate themselves and come into those of us who help them with their care. And so as a team, we accomplish what we all want. And I love the idea about the triple aim. Let me shift now. You talked about diabetes being a complicated illness, not just about blood sugar. And one of the things that has emerged over the last few years as a critical issue is heart failure. Can you explain for our listeners what heart failure is and why that's important to be aware of, that there are some treatments now for that?
Yes, heart failure really has emerged as a very important issue. Of course, we in cardiology always knew heart failure being one of the major types of heart disease. But when we come to this intersection of diabetes and heart disease, heart failure has really been, we were kind of missing the boat on it, to be honest with you. I mean, Darren mentioned that the the community was kind of fixated on blood glucose initially and kind of not recognizing that it's just one facet of the disease process. But the other things that we were really not paying attention to is heart failure becoming a major complication of type 2 diabetes, on par, if not more important, than atherosclerotic cardiovascular disease. So a great example of missing the boat is when this guidance initially came out and the trials were being designed to study the safety of diabetes medications from a heart disease standpoint. The guidance essentially was focused on events like heart attack and stroke, and really said very little, if anything, about heart failure. And we got really lucky because the investigators in those trials, while the main outcomes we were looking at were things like myocardial infarction, stroke, and death, they actually collected data on heart failure. That's the reason we actually found out that drugs like SGLT2 inhibitors appear to be remarkably protective in terms of prevention of developing heart failure, even treating heart failure if it already exists. In fact, it's one of the probably largest discoveries in cardiovascular disease in a generation when it comes to heart failure, because they're one of the most effective medicines we ever had to treat heart failure. But they, of course, emerged initially as drugs for diabetes to lower blood glucose. So we got lucky, but not only did we get lucky in finding a very efficacious class of medicines for heart failure, both prevention and treatment, which, by the way, works regardless of whether you have type 2 diabetes or not. That's another discovery that happened as a result of all of this. But the other part where we got lucky is that the epidemiology, just looking at what happens in terms of the frequency with which heart failure develops in this patient population, and the adverse prognostic impact heart failure has if it develops in individuals with type 2 diabetes. That, I think, is also something that was greatly underappreciated. Now, what is heart failure? I always tell my patients that it sounds like a very scary term, right? Because it suggests that your heart, which is arguably one of the most important organs in your body, right? You can't live without your heart, that it's failing, right? So that's a really scary term, makes people very anxious. But essentially what it means is that it doesn't necessarily mean that the heart is failing in terms of its pumping function. Sometimes it does, but it doesn't have to be that way. What it means is that the pressures in the heart are elevated, and the pressures in the blood vessels in the lungs tend to be elevated, and you essentially congested. And that's what causes symptoms of heart failure. So the way we define heart failure is really based on symptoms, which are typically things like shortness of breath, exertional intolerance, fatigue, swelling. And it can actually result from a number of different causes, and it can occur in patients that have reduced pumping function of the heart, or even in those patients where the pumping function of the heart is preserved. The key thing to recognize is that the symptoms of heart failure are very common things that happen in people living with diabetes, even people without diabetes that have other risk factors. So, lots of people feel fatigued, lots of people feel a little short of breath when they exercise or try to do some physical exertion. And I think one of the biggest issues we have with heart failure is that it's under-recognized in a large proportion of people who actually have it. And it's a really important public health issue that we need to address, especially in individuals living with type 2 diabetes or obesity. It's frequently kind of ascribed to being deconditioned on, not exercising on a regular basis, or maybe weight gain. But in many of these patients, they actually can't exercise. And the reason they can't exercise is because they have heart failure that hasn't been recognized. So I think, the priority in terms of heart failure is understanding it's a major complication of type 2 diabetes. And there are other risk factors, as I mentioned, like obesity, that it's frequently under-recognized. So the symptoms, which is how we define heart failure, need to be taken seriously and investigated aggressively, especially when people have risk factors for it. And then the last is that we have really efficacious treatments now for improving survival, reducing hospitalizations, improving quality of life if you happen to have heart failure. So there are lots of things we can do to make it better.
That's so important for our listeners to realize. And those simple symptoms, fatigue, shortness of breath, when you're just taking a little walk outside, which we usually assume is, part of life, worth worth letting your doctor know about and let them decide whether or not this is heart failure. There's tests that we do, but bring those symptoms to our attention because, as Mikhail, as you said, there are lots of there are important, effective treatments now available. Sarah, I want to turn to you now to briefly, if you can update our listeners. There were some major changes in the recommendations for treating common things like blood pressure and cholesterol in this year's updated standards of care. You want to share what those changes were with us?
They were definitely some big changes, particularly related to cardiovascular care. And I really think most of those changes actually increased alignment with other clinical practice guidelines that clinicians use from organizations like the American Heart Association and the American College of Cardiology. First, in terms of blood pressure, the definition of high blood pressure was changed from a reading of over 140 over 90 to a reading of greater than 130 over 80. The goal blood pressure was also modified this year in a similar way. Previously, the standards of care had a few different goals depending on certain risk factors. Now there's more simplification here and a goal blood pressure of less than 130 over 80 for most people with diabetes. The standards also made some changes to recommendations for cholesterol management. Similarly, and thinking about how they've aligned with other practice guidelines, these changes included the addition of goals for LDL or the bad cholesterol type numbers, depending on if the person has certain risk factors. The standards also updated to add in details about a few newer cholesterol lowering medications that might be used to help reach these goals if the more common statin class of medications does not lower numbers enough. Examples include ezetimibe and a class of medications called PCSK9 inhibitors. I think these changes do increase alignment with other guidelines, and for us as clinicians have really simplified things, but hopefully it's simplified things for our patients as well.
Great, important points, important things for our patients to know about. We only have a few minutes left. Darren, can I ask you, do you have any final thoughts for our listeners?
I do, and Mikhail kind of stimulated this. We've talked a lot about medical therapies, but I do want to come back to the cornerstone of patients living with type 2 diabetes is that therapeutic lifestyle interventions remain foundational. If physical activity is important, managing weight and eating healthy will underpin all of these therapies we've talked about today. But it is a new era, and I will just amplify the recommendations that these randomized clinical trials have yielded now resulted in what we call a level 1A indication for these medications across guidelines and positions from societies. That means it should be done. And so getting back to the patients being enabled and having a conversation with their their clinician or clinical team, these should be done if patients have access and don't have contraindications or intolerance.
Thanks so much. And Mikhail?
Right. Just to add to what Darren said, I'll come back to kind of my earlier theme of patient empowerment. I know you brought that up initially, Neil, and I think it's just so important. If you are someone who's living with type 2 diabetes, next time you have an interaction with your clinical team or clinician, just ask them about, what is my risk of heart and kidney disease? I mean, these are the two most common and arguably the most impactful complications of type 2 diabetes because of the effects these complications have on your survival and quality of life, right? These things that we really pay attention to. So ask your clinicians about what your risk is, whether you have these complications already, and if you don't, what your risk is, and if there is anything else that you can do to reduce that risk. Is there any other interventions that you can implement to try to keep yourself healthy? I think it's incredibly important. I can't tell you how often it is, especially true. I know we're concentrating on heart disease, but how often I see patients that have had kidney disease as a complication of diabetes, and no one's ever told them, and they're completely unaware. So it's asking these questions, I think, is critically important. And again, you really take charge of your disease management and work hand in glove as a team with your clinician to try to reduce your risk for those important complications of diabetes.
Fantastic, critically important conclusion. Sarah?
As we wrap up, I want to share information about an additional resource where our listeners can go to learn more about this topic. The American Diabetes Association has partnered with the American Heart Association to create an initiative and a website called No Diabetes by Heart. This program aims to reduce cardiovascular deaths, heart attacks, heart failure, and strokes in people living with type 2 diabetes. The website has many helpful educational articles, videos, inspiring stories, and even heart-healthy recipe ideas. When you're thinking about those lifestyle efforts to improve heart health, check out that website to get some more information.
Sarah, as always, thanks for co-hosting our podcast. Doctors Darren McGuire, Mikhail Kosiborod, thank you so much for joining us.
Thank you, Neil.
Thanks very much. It's great to be with you.
And to our audience, of course, thank you. We really hope this was helpful. The idea here is patient empowerment. Take this information, use it, talk to your clinicians, and we all are better for that knowledge. Tune in next month when we'll be discussing critical tips for living with type 1 diabetes. For the American Diabetes Association, I'm Dr. Neil Skolnik, and thanks for listening.